I have been dispatched to a patient, 40-year-old male, who has fallen off a roof landing onto his head. He was water blasting and fell off a 2-story house. His neighbour was the one that called 111. There is no past medical history for this patient, and upon examination, he has a bodgy patch on the back of his head. He's lying supine and he's restless and also combative. He has the vital signs of a heart rate being 50, blood pressure 160 or 90, respiration of 12 and it's irregular, a BGL of 7.6 and a temperature of 37 degrees. He has a GCS of 6 made up of 2, 2 and 2, so I shall call R50 for RSI. Upon calling backup, I have been asked to prepare the RSI checklist.
Roll.
So because my patient is combative, I would like to administer morphine. I've gotten my offsider to check that morphine is in date and the right drug, right dose, right patient. Also sodium chloride. The morphine, I've drawn up 10 milligrams and then drawn up 9 mils of sodium chloride with it to make 1 milligram and 1 mil. For this patient, I'm going to administer 3 milligrams of morphine and then reassess vital signs after administration. So I'm going to put in 3 mils slowly, slow push in 3 mils. And note that down, holding on to it at the same time, and then I'm also going to flush that through just to make sure it goes into the system. Cool. I've also got a drug label on the morphine to make sure that it is well dated and drugs. Awesome. Wow.
Go. Rolling.
So because I am preparing for RSI, I am going to follow the RSI checklist, which is found on page 130. 131. I have attached nasal prongs to my patient. I have pre-oxygenated using a reservoir mask at 10 litres per minute. I also have a manual ventilation bag prepared with PEEP set to 5 and capnography available. I am constantly monitoring my patient with a 12 lead and ECG. Okay, so after administering morphine, I've rechecked the vitals and they're all within normal parameters and nothing changed. I'm now going to predict for RSI. So I pop out my pocket ECGs, which have my RSI checklist on page 131, and I shall now follow this, verbalizing it as I go. I've attached nasal prongs to the patient without oxygen running. I've also pre-oxygenated my patient with a reservoir mask running at 10 litres per minute. I've attached an ECG to monitor the heart rate, a blood pressure cuff to take constant blood pressures every 3 to 5 minutes. I've also got SpO2 available to manage to see saturation rates. I have my manual bag mask available with PEEP on and capnography for CO2 administration or checking. I've positioned my monitor so that it's easily seen, and I've left space to the right of my patient's side head of my, oh fuck.
Down.
So after administering morphine to my patient of 3 milligrams, I have reassessed vitals and found that they're all still within normal parameters. Because my patient has a GCS less than 10 and I've called the R50 to come for RSI, I've been asked to prepare RSI for my patient. So I will use my pocket CPGs in order to use the RSI checklist on page 131, and I shall follow this word by word. I've attached nasal prongs without oxygen. I am pre-oxygenating my patient. The reservoir mask at 10 litres per minute. I also have my manual ventilation bag with PEEP set to 5, capnography present, in case I need that. Positioned my monitor so that it is easily seen by both people, all the crew. I've set space to the right side of my patient for RSI to be readily available. I've gained IV access in 2 sites. I've prepared a running line of sodium chloride, positioned my patient for optimal airway. I've placed an ET tube holder underneath the patient's neck. I've ensured my suction is working by turning it on and off. I've got my manual ventilation bag prepped. I've obtained another set of vitals, still the same, being heart rate 50, blood pressure 160 on 90, respiration rate of 12. And upon auscultation of that, there is a bit of a regular rate. I've updated my OSCP on the way to say that I've prepared for RSI, and also ensured that everything is sound and secure and ready for them. After my RSI qualified intensive care paramedic is locked up, they've attempted to intubate my patient. However, with a failed attempt first time, they have one more attempt to try and get a ET tube placed into the patient's airway. If that is failed again, then there is a possibility that the patient can go back to airway adjuncts such as an OPI, NPI, or a LMA. And if that fails, then you could do an emergency cricothyroidectomy, where we cut through the cricothyroid membrane, open up the airway, and stick the tube right through there in order to maintain the patient's airway. This is what we call a bougie. That goes down into the patient's airway and past the vocal cords to allow the ET tube to slide down over the bougie into the patient's airway, and then the bougie comes out. It is more of a guiding stick than anything else.